Thanks very much. It's a great pleasure to be here. And as I said in previous presentations, I really appreciate the work of the TAP executive and the invitation from the president and the executive members. It's always good to be at the TAP. It's a wonderful meeting. So this is a topic close to my heart. I sit on a working board for an addiction treatment center for men. That's a residential treatment center where men can stay for up to 1 year for inpatient treatment. And it's the only center that has constantly had a harm reduction program for opiates. We've heard today about experiences in Turkey, in Canada, and in the Netherlands. And the big question for me wrapping up is harm reduction or total abstinence. So implications for society, the law, and health. From a societal perspective, as you've heard, it really depends on what people think and what people want. And what people want is not always what's good for them. In terms of the law, the existing laws and consequences are important. Sometimes laws are badly written. So many of you will know about the 3 strikes law in the United States. They had a law imposed where they decided that if it was the 3rd conviction, the accused, if indicted, would be in jail for life. This had a massive effect on American society because some middle-class casual drug users, not understanding the consequences, would have their 3rd conviction, and actually the judge had no option but to send them for life imprisonment. This has been a huge issue in American society. In terms of health, which is the mandate of most people here, the impact of drug availability is important in relation, I think, to 3 things: age, vulnerability, and disease. And our previous speakers have spoken to each of those. Brain and body development is really important in the context of aging. Vulnerability in terms of social context and the social determinants of health that go far beyond the person who's using but affect the family. Disease, some people are vulnerable to development of addiction, issues of toxicity in pregnancy, and issues of behavioral disruption in normal life, working and socially. So we know that the imposition of an abstinence policy through prohibition can have massive negative consequences. And this was seen in prohibition in the 1920s in the United States. Looking back, you can see the only real impact of abolishing alcohol consumption in the U.S. was the rise of organized crime. Before Prohibition, the mafia did not really have any foothold in the U.S. After Prohibition, they were a major and still are a major organized crime presence. So one has to be very careful about legislating complete prohibition. And alcohol is an interesting case because if we were to try and legalize alcohol today, nobody would agree to legalize it. As the previous speakers have mentioned, it causes birth defects, it causes brain damage, it causes social disruption, family violence, terrible drug. And as I'll point out later from our friend David Nutt, it comes out as the most dangerous drug for recreational use. Canada did legalize marijuana in September 2018. Here's a picture of our Prime Minister pondering over what you see there as a bud. There's a lot of controversy about the ins and outs, and Professor Durson gave a very good account of the law and consequences. In terms of health, we're always concerned with perinatal effects, and I've chosen a few studies that I mentioned in a previous presentation at TAP on cannabis just to illustrate the problem or lack of problem in terms of severity. A really good paper from last year by Kroom and colleagues looking at cannabis use during the perinatal period in Colorado, which has legalized recreational medical marijuana, association between maternal characteristics, breastfeeding patterns, and neonatal outcomes. They looked at over 3,000 women in a Colorado risk assessment monitoring system. Perinatal use at 5.7%, associated with a 50% increased likelihood of low birth weight. Small for gestational age, preterm birth, and neonatal ICU admission were not actually associated with marijuana use despite that decrease. I'm not going to go through this table. You can have the slides from the website, but you can see the maternal characteristics, the use patterns, and which trimester. Again with that one. The bottom line with this study is that use during pregnancy was greater in the 18 to 25 age group at 7.5%, and the profile of those people indicated a problem with health education. They were young, uneducated, they didn't use folic acid preconception, unplanned pregnancies in women that were not doing well. From the physician's perspective, we look at medical use and recreational use, and the thinking is actually context dependent. From this paper by Zolotov and colleagues in 2018, the issue of cannabis as a harmful and illegal drug, but also as a potential medicine, depending on the orientation of the family physician, the psychiatrist, or the particular specialized practitioner, opinions vary. There's no consensus of how cannabis fits into medicine. Different views are expected to continue the challenge of the integration of cannabis into medical practice. Dr. Durson talked about the person prescribing upstairs where there's a cannabis boutique downstairs. There are also people prescribing in a hospital environment for things like pain and MS, but there's a variety of practice patterns. Adverse effects in psychiatry in terms of mental health have been touched on in some detail. And one of the areas that hasn't been looked at much is dysthymia, although people have looked at depression, panic, psychotic episodes. And in this study of dysthymia, which was last year, they did a multi-cohort analysis, and it didn't come out with as big a problem as has been previously reported. I think most of us would agree that the major issues with cannabis use are around precipitation of psychosis and panic, especially in young people, and the question of whether it's drug-induced or if it was inevitable but just precipitated by the drug is something that's very difficult to disentangle. But the risk is high enough that it's a warning flag for many of us. Impact on emergency room visits. As Dr. Durson said, Colorado legalized cannabis, and there's a multi-year experience of what happened. One of the strange things about the US that Serdar mentioned is the difference between federal law and state law. So if you're in Colorado, you can use cannabis, but if you're outside Colorado at the border, you can't transport cannabis. It is actually a federal offense. It's a violation of narcotics law in the US. When Canada legalized marijuana, one thing happened that Canadian businessmen did not think about. I remember my banker saying, Andy, you should invest in cannabis futures. There's a lot of money to be made in cannabis futures. And I said, I could never do that based on my own ideas about what's right and about mental health. So I said, no. But people I know who arrived at the US border who had a history of investing in cannabis futures, some of whom had houses in Malibu and other places, were told by the US Immigration and Border Control people, Homeland Security, I'm sorry, you can never come into the United States again because you've committed a felony by investing in organized crime to support narcotics. And so those people are banned permanently from the United States. Even though they weren't trafficking drugs, they were identified as having invested in the drug industry. So there are lots of unforeseen consequences. Impact on emergency room visits. This was a study by Wang and colleagues on legalization in Colorado, looking at adolescents, the vulnerable group, and emergency and urgent care visits. So looking at marijuana visits associated problems, 71% of adolescents attending the emergency or critical care units had a psychiatric diagnosis. Most depression, mood disorder, conduct disorder, anxiety, panic, attention lower number of schizophrenia and psychosis, and common co-ingestants, so used also drugs, were ethanol, amphetamines, benzodiazepines, opiates, cocaine, and so on. Although the national survey data indicate no difference in adolescent marijuana use, these authors report a 10-year increase in marijuana-associated visits to the hospital. And in Canada, since legalization, talking to emergency physicians and family docs, anecdotally, they report increased problems with marijuana just recently after legalization. And clearly, there is a significant need for more education in relation to the comorbidity of marijuana use and psychopathology, particularly in younger patients. So, legalization impact. Did medical legalization alone make a difference, or was it recreational? So here's a graph that many of you may have seen before from 2005 to 2015. The first blue arrow is when medical marijuana was legalized, and the second one is the legalization of recreational. The important thing to note is before the recreational legalization, there was still an increase in the number of visits. And this is very much in keeping with our understanding of what happens after the legalization of marijuana for medical purposes. Some people will do whatever they can in terms of how they present to a medical office in order to get a prescription for medical marijuana. So medical legalization, the rules get bent a little bit, and patients push the envelope on symptom prevention to try and get access actually for recreational use. Expanding and variable legalization of cannabis in multiple states nationwide represents an additional challenge for patients and the medical community because recreational and medical cannabis are irresponsibly overlapped. In this review of therapeutics from 2018, the observation was made that cannabis designed for recreational use is increasingly available for patients, which exposes patients to potential harm, partially because the concentrations of active ingredients can be much higher in recreational use shops. So medical cannabis programs in countries like Israel and Canada for pain patients have shown real benefits of separating recreational and medical marijuana sources. Differences between medicinal and recreational cannabis have been touched on. According to a 2009 report, the highest THC concentration for cannabis was 37%. In 2009, it was 13%, and it used to be 3% in the 1980s. So the potency and richness, as you heard for the Netherlands, really has changed with selective breeding. High THC cannabis is readily available in dispensaries of cannabis stores. And here there's, for example, a list of websites. Now, to go on these websites, you usually have to say you're 18, but there's no proof, and off you go looking for what's available. Here's a graph that indicates the level of THC and the relative risk associated with that. So when you get up towards 15%, you're in the area of recreational use where psychotropic effects are very apparent, and there's an increase in intensity with higher concentrations. And in this range, if you think about young people using, and Heval mentioned the issue of edibles or space cake, not knowing about that and taking more before you feel the effect, there's a possibility for very high dosing. Dr. Durson mentioned the conversation between David Nutt, our friend who's been here at the TAP, and Sir Robin Murray at the Institute of Psychiatry. And this is the website, the link for that discussion. The view really depends upon the perspective you want to take. Some people will say that cannabis and cannabis-related products are relatively safe. Other people will say no. And the public takes whichever information they want to confirm their position. And government has been quite selective in the same way. So one of the things that was done in the UK in 2010 was David Nutt and colleagues did a study of harmfulness of drugs. And they used a multi-criterion analysis. And many of you may have seen the general diagram, but you probably haven't seen the extent to which they did the analysis. So they looked at overall harm to users and to others. Where I mentioned family consequences of someone who's a user, think about alcohol. The alcoholic has an impact on the family. The drug user has an impact on the family. So to the others, physical and psychological harm and social harm. To the users, social, psychological, and physical harm. And all of these things include drug deaths, damage to the body, dependence, loss of assets, injury, crime, environmental damage, family conflict, economic cost, and community impact. This is the graph for which David Nutt was fired by the UK government because he identified with his colleagues alcohol as the highest risk drug. Of course, alcohol is socially acceptable in many places, even though it's the most harmful recreational drug known to man. If you look where cannabis is here. So about the midpoint in harm. But people don't discuss alcohol the same way as they discuss cannabis. And alcohol is known to be a long-standing problem. Here is a piece of information that came from South Florida Coalition Against Drugs. So you have a poster with the negative effects of marijuana, short-term effects next to the girl, and long-term effects next to the boy, are all documented, but not put in the context of severity, and emphasizing the downside. So I'd like to point out that one of the problems with age and legalization and the issue of 18, we realize that the brain develops until we're 25. And one of my sons said to me, well, how come people can vote before they're 25? We should change the law. I said, well, if you try and change the law, all the people under 25 would vote you out of office. So we're kind of stuck with 18 as the age of majority. Drugs rarely kill anyone in Portugal is the byline for people who recognize decriminalization of drugs in Portugal. But look at where Turkey is. Turkey is actually number 4. One of the issues here is that the way you present statistics can support an argument for harm reduction or an argument for abstinence. Drug-induced deaths of people aged 15 to 64 per million population. Estonia doesn't do very well. That one's at the very bottom. But Turkey and Portugal have very different drug laws. Portugal decriminalized drugs of abuse, and Turkey retains quite strict laws against recreational use and high penalties for trafficking in drugs. So before I said that, people didn't die that much of drug use in Turkey, we have to be very careful of our numbers, and people in the audience will know more than I do. But I looked carefully, and I found one drug and alcohol review paper from 2016 that estimated high-risk cannabis and opiate use in 3 Turkish cities, Ankara, Istanbul, and Izmir. And they looked at capture, recapture, and multiplier methods, and they based this on treatment and police data, so from the regulatory side and from the psychiatric support side, and stratified by age and gender. For 2009-2010, they used ICD criteria for cannabis and opiates. And in fact, high-risk cannabis use prevalence in both Ankara and Izmir were considerably lower in comparison to a city like Berlin. The rate for Istanbul was only slightly lower than Berlin. But it seems that Turkey does quite well in terms of avoidance of drug use compared to other places. And compared with the majority of cities, because they included it, high-risk opiate use was considered rather low. It was so low in terms of reported police and treatment that it was not possible to estimate the amount particularly. So, in the end, harm reduction versus abstinence, you've heard a lot of information about Turkey, Canada, and the Netherlands. Cannabis is a harmful drug. It's also chosen by people to use recreationally. It's clearly less harmful than alcohol. And perhaps most appropriately, in the real world, the choice of harm reduction versus abstinence really depends on the context and the choice of society. So here in Turkey, you have quite strict laws. Canada has taken that big step and actually not decriminalized, but legalized cannabis use. And 30 grams in the imperial system is an ounce. So an ounce or 30 grams of cannabis is a lot for one person to use. So as Dr. Durson said, it's the experiment in Canada that we will watch and see what the consequences of legalization are. But in Canada, I haven't noticed a lot of difference. Society carries on the same way. There are relatively few people smoking cannabis on the street. We have quite strict smoking laws, and so people that use space cake would not be detectable, but people are not allowed to smoke tobacco or other products or even e-cigarettes in public places, and that probably has taken away a big problem that we might have seen otherwise. In a community where smoking is allowed, as our colleague who asked the question commented, it can be socially very inconvenient for the people around in terms of passive smoking. So I'm sure there'll be lots of conversations about this evening. It's a very hot topic. So I'd like to thank my fellow speakers who I really enjoyed listening to, and I'd like to thank the audience for staying late and listening to my presentation. Thank you so much.